On this episode of the ASC Podcast with John Goehle, we discuss the latest news, talk about upcoming conferences, discuss electronic medical record implementation, and interview Katie Pierson about how to survive software transitions.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, SIS. SIS's mission is to deliver solutions and services that help surgery providers, regardless of care setting, improve their organization so they can deliver the highest level of care to their patients. For more information, go to sisfirst.com.
Welcome to episode 208 of the ASC Podcast with John Goehle for December 6th, 2023, recording from our studios in Spencerport, New York. This is Sue Cronkite, co-host of the ASC Podcast with John Goehle and operations manager for Ambulatory Healthcare Strategies. We would like to remind our listeners that the ASC regulatory environment is a rapidly evolving landscape, and the material presented in this episode is based on the most current information available as of the date of recording. As such, it is important to recognize that the information may be subject to change, and we advise all ASCs to stay up to date with the latest regulations and guidelines issued by their relevant regulatory bodies. Joining me today is John Goehle, the owner of Ambulatory Healthcare Strategies and one of the most respected experts in the ambulatory surgery industry. With over 30 years of experience, Mr. Goehle has authored over 10 books on the ASC industry, and he is a sought-after speaker on regulatory accreditation and finance issues.
So happy holidays to everybody. We survived Thanksgiving, getting ready for a wonderful Christmas. Sue, you and Amy are getting close to something important. What's happening?
Well, Amy, my daughter, is due to have her baby, a little girl, in, I don't know, in the next, at the very latest, it'll be about a week and a couple of days.
Yeah.
But it could happen anytime, really. So
that's kind of why we're recording these things as quickly as possible. I might have to do a couple of them just to kind of get ahead a little bit. Mm-hmm. We have been very busy. We're revising 3 of our books right now, actually. So Sue has been helping me with the survey guide. The conditions for coverage book is just about done. And we're still working on some other projects too, but so very soon you'll have our new books out there. I know the survey guide hadn't been published since 2020, actually, just before the pandemic in February of that year. So very excited about that getting updated. So thank you, Sue, for the hard work you're putting into getting that up to speed. And then, of course, we have a lot of conferences coming up. We just finished the Finance and Accounting Introduction to Finance and Accounting and the Conditions for Coverage conferences. And they were our second and third most attended conferences of all time for our company. So thank you for everybody that signed up for it. And they are now available on demand. So if you want to listen to a recording of those 8-hour conferences each and get AEU credits or certificate of attendance, that is available now. All you have to do is go to ASC-Central.com. And you'll get all the content that we discussed during the live conference. And if you give us the codes that are throughout the recording, we can issue the AEUs. They get 8 credits each, as I think I mentioned. And then January 11th and 12th, 2024, we have our Credentialing, Privileging, and Peer Review Conference. It is already filling up. We're kind of surprised at the interest in this so soon. It's more than a month away, but we have a lot of signups already, and I'm pretty sure it's going to be a very successful conference also. So for more information about that, go to asc-central.com. And Ann Geyer is going to be coming back. Ann retired in May of this year, and she's agreed to come back and do the session on peer review. And she's also going to be helping us out on we're going to do a mock survey during the second day of that conference. And then we do have our ASC Administrators Boot Camp. That's going to be January 23rd through the 26th. We'll be celebrating the third year of the ASC Administrator Boot Camp. That was our first boot camp that we introduced in 2021. So very excited about that. And we also have announced our next business office manager conference, and that is going to be March 12th through March 15th in 2024. And again, all of these you can sign up for at asc-central.com. So let's move on to recent news. There was a recent article in U.S. News and World Reports indicating that they are updating the way they are doing the surgery center ratings and rankings. And they've also modified the timing of those rankings. So U.S. News has for decades helped patients identify the best hospitals for a wide range of medical specialties and services. And in 2024, they're now going to broaden that focus to encompass ambulatory surgery centers. So their intention is to introduce ratings of surgery centers for several different specialty areas. I'll give a link to the article about this, but what they're doing is they're creating these rankings from publicly available information. They're going to use several measures of patient outcomes, such as emergency department visit rates and costs associated with potentially avoidable complications. And they've teamed up with the healthcare analytics firm Care Journey, which has analyzed Medicare claims to calculate risk-adjusted rates of several outcomes for numerous types of procedures performed in ambulatory surgery centers. And they're developing this methodology to combine relevant measures to produce a composite rating for each of several key specialty areas: orthopedics and spine, gastroenterology, urology, ophthalmology, for example. And they're hoping to release the first edition of this in the first half of 2024, and more details will be forthcoming. We're going to keep a very close eye on this. So they are going to be doing the rating for all Medicare-certified ambulatory surgery centers for which the U.S. News has sufficient data. And they indicated that there's approximately 5,000 centers in total. We do know that there's about 6,000 centers out there, but they're probably correct that they might only be able to get enough data for 5,000. Sue, one of the things I found interesting is the centers do not need to take any action in order to be considered, nor can they opt out of being evaluated. So keep in mind that all of the data that's out there in the Medicare databases is going to be available and be used to make these ratings. Unlike the Newsweek system, which is very different than this, this is actually not going to have any input at all and no interviews, as I understand it, of the people in the centers. So they recognize it's an ambitious undertaking, and it's going to require quite a bit of time and effort on the part of the news staff. But it'll be interesting. I think, I'm a little concerned about it because you just never know how accurate some of this information is going to be. And I think we in the industry keep a very close eye on it and be prepared for any of the ramifications of these rankings coming out.
And I have a couple recall alerts from the FDA. So the FDA issued a safety alert on November 30th concerning plastic syringes made in China. They're investigating the possibility of poor quality that could result in breakage, leaks, or other problems. Currently, this does not include pre-filled or glass syringes. So they recommend checking your inventory for the manufacturing location and avoid purchasing plastic syringes that were sourced from China until this issue has been resolved. However, they did note that if you only have syringes that came from China, just monitor them closely for breakage or leaks if you do need to use them.
We will give a link to that notice from the FDA.
And there's a recall of saline and sterile water products that were manufactured by Nurse Assist, LLC. They are sold under several different brands and different sizes of bottles, spray cans, and syringes. They found these products may not be sterile. They could be contaminated with bacteria. These products were sold under the following brand names: Nurse Assist, Cardinal, Covidian, Halyard Owens Minor, IDEX, Mac Medical, McKesson, MediChoice Owens Minor, Medline, Sol, Stericare, Trudel, and Viair. And I may have mispronounced some of those. Yeah. The recalled products may be available as individual units, or they could be included as part of a kit. So more specific product information, including the UDI or unique device identifier, can be found on the FDA website if you need to check specifically for something that you have.
And we'll give a link to that also. These are relatively common products that are being used in surgery centers, so it is important to keep an eye out for them.
And in USA Today, I hate to bring up COVID again, but from November 29th, reported that a subvariant of Omicron, BA.2.86, has tripled in the U.S. in the last 2 weeks, and it now accounts for nearly 1/10 of the cases. Although it's now been classified by the World Health Organization as a variant of interest, they and the CDC say the variant's risk of causing severe illness is low compared to other variants. So that's good news. Hopefully
looks like
we'll
it's
just
starting
keep getting milder forms.
Right.
And there's just been a lot of news about hospitals having to postpone or cancel surgeries due to the shortage of anesthesia providers. So I just wanted to talk about a couple of them. Two of the largest hospitals in Portland, Oregon, have had to greatly restrict the number of surgeries in the last month. One of the hospitals was only accepting emergency and OB cases for a week or two near Thanksgiving. And in October, Cheshire Medical Center in Keene, New Hampshire, started postponing some elective surgeries and also began doing surgeries on Saturdays to kind of spread that out to try to accommodate as many as they could fit in with their limited anesthesiologists. Canada's also dealing with this issue. In August, 84% of hospital chiefs said they needed to hire more anesthesiologists to be adequately staffed. According to Verilon, the shortage is expected to grow to 12,500 nationwide by 2033. While the number of physicians increased by 7% from 2016 to 2021, the number of anesthesiologists only increased by 1.1%. They pointed out that many states have started opting out of physician supervision requirements for CRNAs, as is allowed by the federal government, but not allowed by all states.
Right.
Of course, the CRNAs have a lower level of training, but they did say the pay for CRNAs is also increasing as they begin to fill in the gaps. So the financial benefit of hiring CRNAs may begin to decrease. So it's not really the whole answer.
Yeah, we're seeing we're definitely seeing this affecting a lot of our clients over at AHS, and our listeners, our patron members, have been noting an increase in problems here. And I think if it hasn't affected you yet, you need to be prepared for it. Treat it goes without saying, you should be treating your anesthesia providers well, of course, and do whatever you can in order to accommodate their reasonable requests, because losing them at this point could be quite detrimental to your operation. I think we're also seeing a lot of surgery centers considering different anesthesia provision models, including bringing CRNAs in-house. We're also keeping a very close eye on what's going on with RN administered conscious sedation. We mentioned, I think in our last episode, a situation in Pennsylvania where they're not allowing RN administered conscious sedation, which hopefully is not going to spread throughout the rest of the country. But that could be another potential solution. But of course, that comes with risks also, because RNs again don't have that level of skill. And I guess I can speak for a lot of the nurses. They don't really want to take on that responsibility necessarily.
It's a big responsibility unless you have a lot of training and a lot of experience in it.
And it's not like we have a lot of RNs laying around either. So
no, that's not really the answer.
That's right. It's not really the answer. So we're going to keep a very close eye on that.
And lastly, I saw an article in Outpatient Surgery Magazine in the November-December 2023 issue, had an article titled, "Is EHR Adoption Critical for ASCs?" And they noted some of the benefits of having an EMR include the ability to standardize your data in a way that can improve patient care, save time, and help to meet regulatory and accreditation requirements. You can reduce the risk of prescribing the wrong medication or ordering redundant tests. It's just easier to track all of that stuff in an EMR. Enhance your ability to track and report quality measures. Some of them, can really pull together a good set of data when you need it. Although it will take some dedicated time to implement an EMR system, and staff may be resistant at first, you should eventually save time on printing, scanning, and the storing of paper records. So the upfront investment in time really should pay off, as Katie, who we talked to a little bit later, she mentioned in the interview, the more you can customize the program in the beginning and take the time to train your staff as well as a super user that can help other people that run into problems, the better your ultimate outcome will be. Also, working with any particularly resistant staff is important, because just, one or two people that are doing a lot of complaining can really affect the mood that surrounds any kind of a change. So it's really important to kind of get everybody at least buy-in to a certain extent. The article noted that currently most new ASCs are starting up with an EHR in place, but only about 20 to 50% of existing ASCs have switched to an electronic format. Now, 20 to 50%, that's a really wide range.
Right.
I don't know.
I think it is closer to 50%. And as Sue mentioned, we're going to interview Katie in our second segment here. But this is, I think there's a lot of resistance. I got to admit, as a surveyor, when I go out, I really don't like electronic medical records.
Yeah.
It's so much more work to go through and review and evaluate EMR systems rather than just being able to scan through a medical record quickly on paper. But again, I've been in the industry a long time. It was all paper when I first started, and I kind of grew up in that environment. But most people coming out of school now have experience with EHRs, and most people that are coming over from the hospital have had experience with an electronic medical record for a very long time.
Yeah, or even, when I was in the hospital, I went through a changeover, and it just seemed so daunting, and nobody really wanted to learn it all. It seemed like it was so confusing, but after a year or two, when the power would go out or something, it seemed really daunting to go back to the paper. It just seemed so antiquated. So you do get used to it. It is a big dedication of time and trying to make sure you've got everything really in place and just how you want it before you implement it.
Yeah, and to that end, our very dear friend, Katie Pierson, and she does have a very important announcement during this interview, so stay tuned for that. But Katie agreed when we were thinking about talking about EMRs. Katie had just gone through some major implementation with the SIS system, our sponsor, and the sponsor for this episode. And we thought that she'd be a great person to interview to kind of talk. Often when we do interviews, we talk to the vendors, and here we are talking to somebody that you actually lived through it. And of course, those of you that have heard Katie previously on the podcast know she's very engaging. So let's take a short break here, and when we come back, we'll have an interview with Katie Pierson.
When it comes to the financial outcomes of your ambulatory surgery center, it has never been more important to maximize revenue, tighten the time to bill and collect payment, and reduce denials from payers. Yet without a keen focus on your revenue cycle, it can be difficult to achieve the results your center needs to remain profitable. The revenue cycle experts at Surgical Information Systems can help. With revenue cycle services from SIS, you can improve the financial health and performance of your ASC. SIS Revenue Cycle Services takes care of all aspects of the revenue cycle, including compliant coding based on documentation, claim preparation and submission, claim management, accounts receivable management, billing follow-up, month-end reconciling and closing processes, standard and customized reporting, and patient portion due and/or balance management. By doing the heavy lifting, SIS Revenue Cycle Services leaves you to do what you do best: provide affordable, high-quality care. In addition to managing your revenue cycle, the SIS RCS team uses a 5-step process to monitor, analyze, and make recommendations for improvement to your revenue cycle performance. More than 50 ASCs enjoyed these results from SIS Revenue Cycle Services every month. Faster claim submission, shorter time to pay, improved AR follow-up, higher net collections, expert coding to meet exact payer requirements, and an overall more consistent revenue cycle. Visit sysfirst.com to learn how the revenue cycle experts at SIS can deliver improved financial health for your ASC. Again, that's sysfirst.com to learn more about SIS Revenue Cycle Services.
So I'm here with Katie Pierson. Katie is an old-time friend of ours. She's been with us with the podcast for many years, and we thought we'd have a conversation about implementing new computer systems and how best to interact with the vendors, the types of things we have to watch out for when we're implementing systems and some of the pitfalls people run into. So welcome, Katie.
Thank you so much, John. Thanks for having me.
My pleasure. Katie, tell us a little bit about yourself for those few people who don't know you already.
All right. Sure. Well, I have been a nurse for almost 20 years now. Through that time, did acquire my bachelor's, master's, and then doctorate in nursing practice. And then I have been in the ASC world for about the past 6 years of that, most recently an administrator at a pain management facility.
And that's why your doctorate, of course, is quite unusual, and that's one of the reasons we call you Dr. Katie, just to pick on.
That's right. That's right. John likes to remind me.
So, one of the major issues that we run into, well, first of all, I mean, we all know that we're all heading toward basically computerizing, the EMR, and ambulatory surgery centers have been very slow to adopt EMR systems. And to the best of my knowledge, we aren't even necessarily over 50% penetration yet nationwide, especially smaller centers. I think the larger centers have all been heading in that direction. But so why don't we start by just talking a little bit about your history with moving toward an EMR system? Because I think you've worked on it more than once, correct?
Sure. Yeah, absolutely. So I found it really interesting spending most of the beginning of my career in hospitals when I moved over to the ASC world, how little technology had been adopted, right? Because I assumed with surgery being a little more lucrative, that I would have seen it more. And
Right.
then in using so much EMR in the hospitals and then going to paper, back to paper, I almost felt like I was taking a step back in time. So I have been very motivated and enthusiastic about getting technology adopted in the ASC setting, all the way from implementing EMRs that are out there to even helping build a homegrown system, because I'm all about helping, make the work easier, make the data more accessible, and and we're in 2023. I don't understand why this is still taking so long time to get going.
I find it interesting sometimes when we're recruiting doctors away from a hospital into the surgery center setting that they are literally shocked when they have to go back to paper.
Yeah.
And of course, they're problematic because they're used to, big hospital systems, and even if they were on an EMR system, they find quite a bit of a step down from what they're used to in the hospital.
That's right. Yeah, they have all the bells and whistles in a hospital system, and then they come here, and it's a lot more simplistic because it can be also, but it does create a little bit of a shock to even the learning curve of, wait a minute, but what about all these other features I'm used to having or having accessibility to?
Yeah. Yeah, and I think that gets to the heart of our discussion today is, how does an organization that has a history of being on paper adapt to a new system, and then integrate people that are coming with a lot more experience in EMRs than many of the people that have been with a surgery center for a while. I think when we're setting up a new surgery center, they often, immediately implement an EMR. I'm finding that more and more. It's mainly the older organizations with nursing staff or or all kinds of staff, that have a long history of being on paper. How do they go about that? And my experience has been it's often a very difficult transition. I know that's what you've experienced too when you've come into existing organizations.
Oh yeah, it's turning the Titanic in that respect, because you have a lot of folks who will hold on to that piece of paper for dear life until you physically rip it out of their hands. And even then, they're still trying to find a way to get it back. So the most success I've seen in getting this done is it's usually sparked by one of your highest influencers, whether that be the administrator, medical director, someone that says, we need to do this. We need to get this done. What do we need to do to get this done? And then putting a lot of manpower and energy into that. You really need to have somebody that is motivated, or hire somebody that can help get you motivated to do it. There are, folks out there that can help implement them as well if you're unsure of. So I know it's possible, but I think it's really having that buy-in from someone with the authority to say, this is what needs to be done. And sometimes it's just a matter of, hey, my friend is using it. They said it's super easy. How do we get it here? Right. Or I've seen someone else do it, or, the payers, and it's where we're going to be going in the next 10, 15, 20 years, the nurses are all complaining because we're still on paper. I mean, there is usually a motivational factor there that's driving the implementation of something like an EMR. But, and then it's taking that flame and running with it, because nothing, stops progress more than, your administrator then leaving or something like that. So it's keeping it going, and then sometimes breaking it down into smaller pieces. Maybe not implementing the entire EMR, just implementing the nursing charting aspect of it. Break it up. It can be done that way as well.
Well, and actually, that brings up a very good topic, because the major systems out there, for example, SIS, our sponsor here, they have the business system, that does their billing, coding, and registration, and then you got the EMR system, and then there's other modules that come with it, and that's right. A relatively cost-effective way to implement it, and of course the other major systems out there, HST also, has similar attributes. But I think one of the things that we find extremely important is not rushing into this, correct? And so
absolutely.
A little bit about, your advice there, having been through this before, how you do that. And also, bring into it that these systems can't work on their own. You can't have a business office system that doesn't talk with the EMR system. And that's the danger you have if you're not looking at systems.
Yeah, if you're trying to break it up. And I would say, if you can, at the least, get the billing and charting components built at the same time, so they can talk to one another. Because to your point, then it is more work, technically, at the end of the day, trying to put the data from one into the other one. You are still having that manual process of having to have the two talk to one another. There isn't that true integration. So for sure, my piece of advice would be, if you can do the complete product, at least those two, 100% try to do that. And then you can add the patient portal or the scheduling office piece, or, other things like that. Anesthesia even can come later, because it is crucial in that respect to get those going.
So walk us through what you think is the ideal way. Let's say that you're using a legacy system, a system that's really not supported anymore for your coding and billing, and now you want to move into the 21st century. Heck, many people just in the 20th century, but let's say the 21st century. But you're going from an old system. Let's say that you have Advanix. By the way, it's amazing to me Advanix is still around, because I worked with it back when it first came out, when Windows first came out. And in my view, it's probably one of the best systems that was ever written out there. So there are a lot of places that still have it, but we know that is not a system that
it's not going to survive the next 10 years.
Right. Let's say that you are an organization that has a system similar to Advanix, and you're trying to move on to one of the new generation cloud-based systems. What would be your step if you were to walk into a surgery center tomorrow that was on Advanix and you're the new administrator? The types of things I think we need to talk about is, what would be your first steps? How long should it take? And what would you be doing with your staff to make sure it's very successful?
Yeah, I think something we all are very guilty of is building something, creating something, and then not looking at it for another 5 to 10 years. And then when you are trying to do something like this, you're trying to squeeze it into the system. Now being part of, especially even SIS implementations, folks will take their Advanix data, their paper chart, and then try to just emulate it onto SIS, thinking that, I'll just take this and then we'll have it word for word reflect into this new EMR. And that's not how it's intended to be built. What I would say is get very familiar with what are the opportunities, what are the options of whatever EMR it is that you're looking to adopt. Have them go through a sample chart and really, either you or have your friend who's super tech savvy understand, how is this going to flow? I've seen it so many times where people will try to, again, throw their paper chart into the EMR and they'll say vital signs stable. And I'm like, but there's a whole vital signs module. Why are you even talking about vital signs over here when, when it's over here in the chart? So
You actually have
it's
more
looking at,
communication if you're not if you're trying to side by side convert from an existing paper or an old style system.
that's right.
Yeah.
That's right. Yeah. And again, looking at your preference cards, looking at what supplies do you actually use, because it's going to be so much work to input that data into the EMR system when you may not have used 500 of those preference cards in the past 4 years. You know what I mean? So cleaning up what you currently have is probably going to be the first step and one of the best things you can do. So then when you are building the system, it reflects accurately what you're currently doing.
Yeah. As I'm listening to you, I'm thinking to myself, I got away from the hospitals, and I know you did too, because we all hate those committees. In a hospital, let's take the two extremes. In a hospital, they would be putting together, 17 committees to implement a new EMR system. They'd be meeting for 2 years, and have 200 or 300 people involved in the whole process, and then implement it and still have a bad product. Very difficult implementation.
Yeah, because it's the blind leading the blind, and I think you're bringing up the point that you really need to make sure you have somebody that has done this before, that understands what they're doing, because it is a very big undertaking. It can be very confusing, and what you don't know, and then it does reflect on the back end, which then of course creates frustration and sometimes even pure hatred towards the system from the staff. So I do know people, if anybody, if they need help, we got you, but please, if you are confused in any sense, don't try to do it alone. And I mean, SIS has a lot of support as well. They're really good at answering questions. You just got to be willing to take the advice and ask for the help too, Yeah.
Well, and actually that brings up a very good point. How much time should be spent with the vendor. I think sometimes we when we implement a system, we look at the default templates that might come in, and then make modifications to them without spending a lot of time with the vendor. The vendors are there to support you.
That's right.
There's a lot of good resources available. Are we using properly or completely, or are we trying to do things on our own? So there should be ongoing communication. So what does that look like? If you're working with a vendor, what type of communication? What could you expect with the average vendor out there? Well, I mean, let's face it, SIS is the major player. So your experience with SIS, talk a little bit about how they would support.
Yeah. With every build they have, I mean, not only do you have your sales representative who's there to hold your hand as best as they can throughout the whole experience, but they also have the implementation specialist that comes on pretty early. As soon as y'all are talking about signing and getting that done, the implementation specialist is there to do that for you, to help you understand what needs to be done, when does it need to be done. They're kind of like your project manager for the whole experience. And then when you do get stuck, either they or they will give you references to reach out to and say, hey, look, these guys have done it. They're willing to talk to you. If you need to bounce some ideas off. I know they have like a good referral program too. So if I am helping another facility out, they'll give me a little, monthly bonus thing. So they do help support and incentivize in that respect. And then I do believe too, they're really talking about helping you put in a lot of that minutia data, like the preference cards and things like that. So you're not spending so much time focusing on that and more on how is it actually going to flow for your center.
And testing it once you get it up and running, or once
exactly
you get the system in place. Well, and so let's talk about that for a second. What type of time frame do you think would be appropriate, or in your experience would be appropriate from when you decide to go with a particular software to when it really goes live or completely live?
Yeah, and a lot of people think this is dependent on how big your facility is, but honestly, there's only two factors for me at the end of the day. First is how much time do you have to spend on it, and number two is how comfortable are the people in doing this, or in having this experience, because working for a 2 OR pain management facility is really not going to take any much longer than an 8 OR multi-specialty because you're going to have more resources to put towards it.
Good point.
Again, it's more about the motivation to do it. So from start to finish, if you're doing it all by yourself, meaning you haven't added any additional consulting along with you, I would say if everything goes according to plan, everything is cleaned up, it could take 2 to 3 months. If you're motivated enough to do it. A lot more folks are taking closer to the 6 to 12 month mark just because they get stuck. They have triple HT coming in the door, or, staff turnover. So, obviously life
during the
happens.
process. Yeah.
Yes.
And talk about super users and their important, what makes a good super user and how would they interface with the vendor?
Yeah, absolutely. So for sure, as early on as possible, identify those folks that really seem eager, interested, and excited about implementing this system for you, because they will be your biggest cheerleaders and assistants throughout this whole. You can't do it by yourself. Let's just be really clear about this. Please don't try to do it by yourself. Get a expert in every area involved. And what I mean by that is billing, obviously, if you're going to include that, and then pre-op, OR, PACU, really just make sure you have and materials management for the supply management aspect of this, and make sure they're involved in as much as humanly possible, but also, if you want to move forward, to your point, don't have 15 committees working on this, because it'll never get done.
Yeah.
And then incentivize them, make them however that looks for you, because it is a lot of work. There's a lot of additional work that you are asking them to do. Give them the time, give them the resources, and then I promise long term, they're going to really take this and own it and help train anybody, not only new the days of, but moving forward, because that's really the biggest thing, is the sustainability of it moving forward as well.
Yeah, one of my pet peeves is that often these vendors go out and they give you these white papers. They talk about return on investment and point out that, you're going to save all kinds of time, with this new system. Well, maybe in a couple years, but
that's right. Yeah, later on. Yeah.
So, in your experience, what type of additional time, might be involved? I know it's hard to pin down, but, just kind of give some examples of what you should expect. I mean, you certainly you can't assume that it's going to go smoothly and that you won't have inefficiencies right from the very beginning. So I deal with that. What do you think?
Yeah. From a go live perspective, I'm assuming is what you're referring to. It's plan for the delays. And I can't stress that enough, actually, where people think that they will push the button to go live and that day they're going to still run perfectly on time. And, there's always a glitch in the matrix, so please just be prepared for that. Have grace, have patience. I would say for every case, let's say every hour case that you do, create that little 10 to 15 minute buffer for those unknowns that might pop up. The assumption is it's going to flow this way. All of a sudden you start using it and it's like, oh my gosh, where are we putting our implants? Nobody even knows. So, it's, I would say definitely put a little bit of a buffer that you can, at least for the first, I would say 3 days. For the first 3 days, those are typically the hardest, because it's not only are you learning the system, but now you're really testing out what you built and seeing if it's making sense from what you assumed. I've seen it too, where folks will go back to the drawing board on Friday then and say, hold on, we have to completely flip the way that we built this OR form, because we actually work this way and not that way. So it's definitely a lot of learning in the beginning.
Yeah, and the best laid plans, you can organize everything as much as you want. When you actually go live, you're going to have surprises. You have to know that you're going to have some surprises.
And, people like CIS and NHST, they have support available. I can tell you, though, moving into this post-pandemic world, the live support has substantially decreased. I mean, they're barely offering it from really all EMR systems out there right now. So it's it is usually a special request or it's an additional cost or something like that. So, if you really want it, you better make sure that you're building that into a contract or an agreement up front, because they won't be as willing to give it to you unless you're asking for it. And I hope I'm not getting in trouble by saying that, but it's true.
Well, I don't skimp on that. Don't skip on the cost of the education,
Right.
if you feel like you're going to need somebody in-house, build it into the cost, because if you feel you need to have somebody sitting next to you, then don't take the risk that you're not going to have the resources available to you simply because you wanted to save $100,
Yeah. Even $1,000. I mean, seriously, it makes a world of difference. I think, this is my personal opinion, to have somebody standing right there next to me saying, nope, you got to click it here, versus I'm available via telephone or Skype or whatever, to remote in with you. It is a remote world right now, but not in a surgery center. We're all still working right there next to each other. So
yeah, I haven't been able to find a nurse yet that can do it from home.
Yeah, exactly.
And it kind of goes without saying that we have to be very careful about those doctors, about the physicians, whoever are practicing on the days of the implementation. You don't want to have the ones that want the fastest turnover, that are running through simultaneously, be the doctors that you're working with, unless they have true buy-in and want to be part of that solution. I mean, I could see that happening, but if you've got doctors that aren't even happy with this process, don't want to give in, don't want to give up any of their, don't want any inefficiencies to come into their surgery day, those are not the doctors to be doing surgery on the days of the implementation.
Not typically the most ideal, definitely. However, take what you can get. If it is what it has to be, then run with it and make sure you're giving them all the cookies and pizza or whatever it is that you need to do to keep the day going.
Right.
Or a dedicated person. Okay, Dr. Smith is going to be our biggest challenge here, so who's going to be on him all day to make sure that he has that white glove service of ensuring that, we're making sure he gets all of his work done. So, I mean, if you got to do that for a little bit to make sure he feels comfortable with the system, then do it.
Yeah. And, and we had a recent experience out in Ohio where we implemented a system, and we even for the board meetings for the year before we implemented a system, they took 6 to 9 months to implement, and then they had challenges in implementing it, just, computer problems, staffing problems. That's actually the biggest problem right now, is that, with the staffing, when you're training people, that's not a good time to implement a new system when you're in the middle of, training a lot of people. But they had buy-in from the doctors at the board level right from the very beginning. They warned them that it was going to be challenging, that they were going to have delays. Most of the people that were practicing at that center were owners. So they kept reminding them, hey, listen, when we go live in August, it's going to be challenging. Be prepared for it. And they also told them, I think, which is a good idea, is that, by the way, cash flow might not be great at that time because of the
additional resources spent on staffing. Yeah.
And so be totally upfront. And I think what this particular organization did is they really portrayed the worst case scenario. And when it still wasn't great. I mean, things happen, but the doctors were prepared for it, and they didn't grumble as much as they would have if they had not been that well prepared.
Right. Yeah. To your point, be as upfront, honest, don't hide anything, because then folks will get resentful of you. So just let them know right up front that at the end of the day, this will be good. It will be better. Staff will be happier. Patients will be happier.
Yeah.
But it's going to be a little tough road ahead until then, for sure.
So I feel like I'm going backwards here for a bit. One thing I've mentioned before is, as you're selecting your super users, as you're putting your team together for that implementation, talk a little bit about, I feel it's very important that those individuals go on the road, visit centers that have already done the implementation, and not just like a courtesy visit to kind of peek in to see how they're using it, but to really spend a day looking, at how that system was implemented, talking to the people. Of course, you got to, find somebody that's willing to do this, and hopefully a friend of yours that investment for you. But talk a little bit about that.
Of course. I mean, again, ideally, you can do that. You can send a couple folks to a facility that has even a similar specialty as you, if you can, right? Because then you can kind of get a feel of what your day will look like in that aspect. But even if not, at least implementing the same system
Right.
is the next best option. If you can get out there, and if not, from that perspective, getting onto a Zoom or a Teams as well to kind of see
Yeah.
their flow, see how they built it, talking to them about what were your challenges, what has worked really well for y'all. I would 100% agree that in any aspect that you can to connect with other facilities prior to your go live and how they've built it, how they've done it, is going to be really pivotal to help your success as well. Yeah, that's a good call out.
Yeah, and I think lastly here, just the importance of the staff training, the importance of being patient with the staff, the importance of understanding that you got to listen to them. And before you say it's time to go live, make sure that they have total buy-in, or at least 95% of them have total buy-in to the implementation and the timing. If they feel like they're not ready, don't push it through just because you've got a deadline to meet.
Yeah, it's really hard, I think, in any time you implement any kind of system because they're not part of the day-to-day build. And so when it does come to the training and finally implementation time, they do often feel like they've been kept in the dark. They don't know what's going on. I just want to see it. I just want to understand it. And I don't know best practice here, but helping them understand that you will get the training, you will understand it, but we need to ensure that it is actually built out before we really go through it. Otherwise, you're going to be set up for failure because it's not what it will actually look like that day.
Right.
And then empowering them to say, how do you feel about this? Do you have any other questions? Does this make sense to you? I don't know how often we do check-ins of knowledge at the end of the day for most kinds of training. Actually, we talk at them for 3 hours and say, okay, go, but to your point, really letting them play with it. We make plenty of test patients in any system that you build. Let them go in and play around with test patients until they feel super comfortable with it. Give them the time to do that before you go live with it, because I think that's really important.
As I'm listening to you, I'm thinking to myself, here's a competency, right?
Yeah, absolutely.
Competencies,
Absolutely.
we do coding competencies.
Yeah.
Seems to me like somebody should be putting together a competency for being able to use the computer system before.
Yeah, absolutely. I'm 100% advocate for that. Yes. Make sure they understand what's going to be expected of them at the end of the day, because they are going to be held accountable to making sure that documentation is complete and accurate, and that they aren't spending 5 hours on it a couple weeks from now.
Right.
Yeah.
So, Katie, you have some exciting news for us, don't you? Actually, we both do. Go ahead.
I mean, I believe we both do. So I am so happy to have joined your team at Ambulatory Healthcare Strategies. Very excited to be working with you all as a regulatory specialist, and can't wait to see what our future holds together.
Absolutely. Katie joined us on Monday, so she's been with us a full 4 days when we're recording this, and she hasn't quit yet. Of course, I wouldn't accept any letter
resignation,
but we are glad to have you on board. You've been a friend of the podcast for so long. You partied with our staff during the ASCA conference, and we've been keeping an eye on you for a while there. We're so glad to have you on board, Katie. Thank you so much.
Me too. Thank you.
Yeah, and you're going to be a regular on the podcast here too. So we'll and you're going to be joining us for some of our boot camps and other things coming up.
Yes.
We haven't worked all that stuff out yet, but because we've only really been together for a week here as
right.
As we
I still need my laptop. Come on.
That's right. Wait for it to arrive sometime today. And to that end, I think it's we are dedicated at the podcast. I think we all know right now that EMR is the hottest topic, and we've been trying to avoid it for a long time, but we really are running out of time. I know the government's not going to tell us, at least not yet, that we have to implement this system. But, if you have not already adopted an EMR system, you better be thinking about it and thinking about it pretty quickly, because the days are limited to be able to maintain a paper record.
Absolutely. And it kind of just supported by, again, the patients, the staff, the doctors. Nobody wants to use paper, but and those that do just don't know how to do the EMR yet. But if you walk into any doctor's office, any hospital, any ASC, and you see paper, some folks are questioning, like, do they have the latest technology going on here?
Yeah, that's pretty good. Well, and at the podcast and in all of our educational programs, I think people are already starting to get the hint that this is a focus right now of our educational programs. And I just want to forewarn everybody that we're not going to stop there. And of course, reach out to us over at Ambulatory Healthcare Strategies if you need some help and advice. And most importantly, reach out to the wonderful vendors out there if you need, references. And of course, don't forget about our sponsor, SIS. They've been with us for almost the entirety of our organization, and all of us here at the podcast and at AHS can recommend them very highly. So, definitely reach out to them. Do you have any last minutes of pearls of wisdom before we leave?
Always. I would say that it needs to happen. Make it happen, and please, please, please don't try to do it alone. If you can help it. I know the healthcare industry typically has very strong-willed, not going to say stubborn, but folks that think they can do everything on their own. But when it comes to implementing any kind of technology, please, please, please reach out. We have done it. We've done it many times, and we've done it well. So please ensure to tap in on your friends and resources, because we're here to help you.
Thank you so much, Katie. It's been a pleasure having you on, and we'll certainly be talking to you again.
All right. Thanks, John. Take care.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff, and other events in the ASC industry.
So ASCA 2024 will be at the Gaylord Palms Resort and Convention Center in Orlando, Florida. That's going to be April 17th through the 20th, 2024. And the AHS and the ASC Podcast team will be there in force. I think we're going to have probably between 10 and 12 people. And, of course, just like we did for 2023's conference, we'll be recording live from there and have a couple episodes that talk about the various events. The Georgia Society of ASCs and the South Carolina ASC Associations, they hold conferences together, so their joint semi-annual conference and trade shows are going to be February 22nd through the 23rd, 2024 in Atlanta, Georgia at the Westin Atlanta Perimeter North. And the second one is going to be August 15th to 16th, 2024 in one of our favorite cities, Sue, Hilton Head, South Carolina at the Marriott Hilton Head Resort and Spa.
And the Gulf States Conference is June 11th through the 13th, 2024 in Biloxi, Mississippi, the Beau Rivage Resort and Casino.
The Florida Society of Ambulatory Surgery Centers Quality and Risk Management Conference will be April 4th through 5th, 2024 in Daytona Beach, Florida at the Hilton Oceanfront Resort. And their annual conference and trade show is going to be July 17th through the 19th, 2024 in Orlando, Florida at the Signia by Hilton Orlando Bonnet Creek.
And the Tennessee Ambulatory Surgery Center Association Conference is September 12th through the 13th, 2024 in Chattanooga, Tennessee at the Chattanoogan.
And just put in your calendar, the 2024 Multi-State Virtual ASC Conference will be tentatively it's scheduled for June 13th through the 14th. We're pretty sure it's going to be those dates finally, and more information to come on that. And those of you that attended the 2023 Multi-State Conference know what a wonderful virtual event that was. And then, as we mentioned in the beginning, the Credentialing, Privileging, and Peer Review Conference, virtual conference, is going to be January 11th through 12th, 2024. This is going to be an update to our 2020 conference on credentialing, and we're going to be adding a lot of new content, particularly in the area of peer review. So for more information about that, go to asc-central.com. And then our previously announced administrative bootcamp is now available to register semester, and that'll be January 23rd to 26th, 2024. And our second ever Business Office Manager Bootcamp will be March 12th through 15th, 2024. All of these are available at ASC-Central.com. And on-demand versions of all of our boot camps, including the ASC Director of Nursing, the ASC Administrators, ASC Business Office Managers boot camps, are also available on ASC-Central.com. And if you're short for IPCH or AEU credits for 2023, an on-demand version of our multi-state conference from 2023, which was eligible for 16 AEUs and 4 IPCH credits, is available on demand. And this conference included a lot of great sessions on infection control, life safety, survey preparation, human resources, introduction to Medicare ASC payment system, pharmacy, staff retention. So for information on that, go to ASC-Central.com. And don't forget about our patron member program, which is also known as ASC Central. It's an exclusive membership website that provides a one-stop ASC regulatory and accreditation, compliance, operations, and financial management resource for busy administrators, nurse managers, and business office managers. And resources include some of our virtual conferences, various links to important information, policies and procedures, forms, and fire and disaster drills. And one of the most important parts of that patron program is the ability to drop into our usually weekly drop-in sessions through Zoom, where you get to talk to surveyors and members of the podcast, as well as some of our employees over at AHS. Membership helps to defray the costs of producing the podcast, including our research staff, travel costs to conferences, equipment costs, and production costs. For more information, you may want to visit ASC-Central.com. Speaking of all those production costs, Sue, we got a lot of new equipment in the studio here, don't we? Are you excited?
As long as I can see the screen, and I really...
She doesn't even know.
You kind of are the control center over there, so you're the one who's got all the extra screens and everything, because you actually run the show. I just kind of...
We've been slowly replacing. Actually, I won't say slowly. We've been replacing a lot of our equipment here to bring it up to date. So we're very pleased to be really ready for our new conferences in January. So thank you for joining us for this episode of the ASC Podcast with John Goehle. If you found the episode informative, we really encourage you to share it with your friends and colleagues in the ASC industry. And don't forget to hit that subscribe button so you never miss an episode. We would love any feedback about our episode or ideas for future episodes by sending an email to comments@ascpodcast.com. And I'd like to give special thanks to our great team here who make this podcast possible. Our sound editor, Sue Cronkite, our executive producer, John Goehle, and our dedicated research team, Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Caloritis, Jim Masters, Amy Dravano, Lori Rodericks, Kathy Foti, Donna Macchio, Christina Norman, and Katie Pierson. We couldn't do it without them. Our music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast platforms. Thank you for listening.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, SIS. SIS's mission is to deliver solutions and services that help surgery providers, regardless of care setting, improve their organization so they can deliver the highest level of care to their patients. For more information, go to sisfirst.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.